Bismillahirrahmanirrahim. Quote of the day is: whoever saves one life, it is as if he has saved whole humanity. This is the ayat from Quran. My name is Dr. Aamna Khalid. I am PGR Community Medicine. Today I will present on the topic of thalassemia under the kind supervision of Professor Dr. Saira Afsal, who is my supervisor and Dean Institute of Public Health, Lahore. Learning outlines for today's presentation are epidemiology and disease burden of thalassemia, public health determinants and risk factors, screening, prevention, and national control programs or strategies, management, economic burden and challenges in lower middle income countries, policy level actions and future directions, recent updates, and then the practice of MCQs. First of all, we start with thalassemia. Thalassemia is the inherited hemoglobinopathy. It is caused by defective synthesis of alpha or beta globin chains. It leads to hemolytic anemia, ineffective erythropoiesis, iron overload, and it's considered a preventable genetic disorder with effective population level interventions. So its pathophysiology includes that there is reduced or absent globin chains that leads to imbalanced hemoglobin synthesis. That manifest the microcytic hyperchromic anemia. Bone marrow incompensation expands and bone deformities appear. Iron overload due to transfusions is there, and increased absorption as well for iron. So this is the same pictorial depiction of pathophysiology, that alpha or beta chain imbalance is there that leads to ineffective erythropoiesis and anemia results, which causes organ damage of the heart, liver, endocrine. Due to the treatment, iron overload is there that further causes organ damage, and bone marrow expansion and bone disease is there, extramedullary hematopoiesis and organomegaly, peripheral hemolysis and gallstones, hypercoagulability, and vascular diseases. There are two major types of thalassemia: alpha thalassemia and beta thalassemia. Alpha thalassemia occurs due to deletion or mutation of one or more of the four alpha globin genes, leading to reduced or absent alpha chain production. And beta thalassemia results from mutations in the beta globin genes that reduce or completely stop beta chain synthesis. So, alpha thalassemia is further classified into four types on the basis of the number of the genes present or absent. Silent carrier state, alpha thalassemia, HbH disease, HB Barr's, hydrops disease. So the first two, one silent carrier state in which one gene is deleted, and in alpha thalassemia, two are deleted. So in both of them, the patient is asymptomatic, and in HbH disease, three of them are deleted, and a patient presents with moderate anemia. HB ranges from 7 to 11, and a chronic hemolytic anemia occurs, splenomegaly as a result, and jaundice. Transfusions are required in this stage. Then the fourth one is HB Barr's disease. Patient is severely anemic. Hydrops results. No alpha chains are there, and excess of gamma. Other chains are there to form the HB different types of hemoglobin. And the HB level ranges from 3 to 8. There is a severe hyperchromic and microcytic anemia with numerous nucleated RBCs, and on the bone marrow, marked erythroid hyperplasia is there. Beta thalassemia is further classified into three types: beta thalassemia minor, that's also called beta thalassemia trait, beta thalassemia intermedia, and beta thalassemia major. In the beta thalassemia minor, a patient has only mild anemia. In the intermediate stage, he has moderate anemia, HB around 7, and in beta thalassemia major, that's transfusion dependent thalassemia, jaundice, splenomegaly, severe anemia, HB around 3 to 7, and mm, uh, iron overload is there, and bone deformities due to bone marrow expansion. We can also classify thalassemia on the basis of the dependence on the transfusion. Either it's non-transfusion dependent or the transfusion dependent. Transfusion non-transfusion dependent is the one in which patients do not require regular lifelong transfusions, and transfusion dependent is the one in which they require lifelong transfusions every 2 to 4 weeks. Severity is less in a non-transfusion dependent and more in transfusion dependent, and HP level is 7 to 10 in the non-transfusion dependent and less than 7 in the transfusion dependent. And beta thalassemia intermedia, HbH disease, and a mild HbE beta thalassemia comes under the category of non-transfusion dependent, and beta thalassemia major and a severe HbE beta thalassemia comes under the type of transfusion dependent thalassemia. So again, this is the same thing that occasional transfusions, if required, that comes under the heading of non-transfusion dependent, and when regular transfusions are required lifelong, then it comes under the transfusion dependent thalassemias. Determinants of thalassemia burden. There are three major categories. The number one are the genetic factors, autosomal recessive inheritance, high carrier frequency in certain ethnic groups, and consanguinity increases risk. Second category is the socio-cultural factors, lack of awareness about the inheritance pattern, social resistance to premarital or prenatal testing, preference for cousin marriages. And third category is the healthcare system factors. There are the weak screening programs, poor access to iron chelation therapy, and gaps in the blood safety and supply. So the clinical picture of thalassemia major is a severe anemia in infants, failure to thrive, splenomegaly, skeletal deformities, jaundice, and due to iron overload, some complications are there, including cardiac failure and endocrine failure. So you can see on the right hand side that a person with anemic hand compared with the normal. This is a thalassemic child with enlarged spleen, and on the right hand side, you can see the facial abnormalities, the bone deformities of a thalassemic child. So the diagnostic methods include a simple CBC, which shows microcytic hyperchromic anemia, or you can see the peripheral smear, HB electrophoresis, serum ferritin, and DNA mutational analysis. Management strategies can include the number one is blood transfusion safety. And the donors should be voluntary, and screening of them should be done for HIV, HBV, HCV, syphilis, malaria, avoiding transfusion transmitted infections. Second is the iron chelation therapy needed because chronic transfusions cause iron overload, damaging of heart, liver, endocrine glands. National programs are needed for procurement and subsidy. Comprehensive thalassemia care centers should be there, multidisciplinary teams comprising of pediatricians, hematologists, counselors, nutritionists, psychologists, and patient registry should be there, helping in tracking burden of the disease and supporting planning for blood products and chelation. So endocrine monitoring should be done. Vaccination of such patients should be done, including HPV. Splenectomy in selected cases when spleen is extremely enlarged and symptomatic. Psychosocial support of such child and family should be done. And bone marrow transplant is curative but it's expensive as well. And there are new management strategies as well that we will discuss further in the recent advances. Global burden of the disease is that approximately 1.3 million cases occur globally. This is taken from the article published in the Lancet about the global burden of thalassemia, and it was published in 2024. They took the data from around 1990s to 2021. So incidence globally is that 1,19,000 cases are reported, new cases are reported annually. Mortality around 11,000. Delhi's is around 8 lakh. Carrier rate is about 1.5% of the world population is carrier, and highest burden lies in the thalassemia belt. And thalassemia belt includes the regions of Mediterranean, Middle East, South Asia, and Southeast Asia. So the burden in Pakistan, the carrier prevalence is around 12 million carrier, 5 to 7%. Around 5 to 9,000 affected births are per year, reported per year, and nearly 1 lakh registered patients requiring lifelong transfusions. And all of this leads to major strain on blood banks, healthcare budgets, and families. This was a study published on the global burden, as well as a burden on Southeast and Southeast Asia. So this study states that Pakistan had highest age standardized mortality rate among all the countries, with death number of around 2,000. Mortality subsequently impacted the Delhi's, and Delhi's were quantified at 1,64,000. So we need to go to the prevention of thalassemia being on the having the highest burden of thalassemia. So the primary prevention is to prevent birth of affected children, and that includes public awareness campaigns, school or university carrier screening programs, premarital screening, and genetic counseling. And legislation should be there, as Iran had the legislation and they did the premarital screening, and they have significantly reduced the burden of thalassemia in their country. As we talked about the awareness that it comes under the primary prevention. So now we see the level of awareness we have in our country. And this was a study published taking the data from children in Balochistan, and it states that only 13.7% of the people recognize thalassemia as an inherited disease, and 91.6% were unaware of premarital and antenatal screening. What is it? And the awareness was poor in 48.9% and good in around of only 4.7%. So the second level is the secondary prevention that targets for early detection of carriers and affected pregnancies. We can go for family screening, antenatal screening, prenatal screening, and DNA-based mutations testing. Majorly screening includes two tests. The number one is the CBC, a simple test, and then we can go for HB electrophoresis. So screening program, if done at a premarital level, is the most effective strategy. Couples are screened before marriage. If both are carriers, they are counseled, and the further options are described to them. And as I have already mentioned, that this strategy, when applied in Iran, they reduced thalassemia births to almost zero. In Pakistan, some provinces have laws, but implementation is weak. Then second can be the antenatal screening. The first trimester screening is recommended if mother is a carrier. Father is also tested. If both comes to be carrier, they are offered chronic villus sampling at 10 to 12 weeks, or amniocentesis after 15 weeks. Early diagnosis allow decision making. um, as I mentioned previously about the fourth category of alpha thalassemia, that was Bart's disease, that abortion can be recommended in that case, taking into account the law and religion. So as I said that law is there but implementation is weak, and this was the bill of Provincial Assembly of Punjab, and they have stated about the blood test for thalassemia before marriage, that the blood relatives of thalassemia patients who are marrying shall be advised and counseled to obtain a premarital blood screening to ensure that they are not getting the trait. So actually we need to implement this law. So the third level of screening is tertiary level prevention, that prevents complications and improve quality of life, and it includes regular safe blood transfusions, iron chelation, management of complications, and bone marrow transplant as curative option. Quaternary prevention, we have to prevent the over medication and unnecessary tests or treatments, avoid excessive transfusions, inappropriate chelation, and non evidence based therapies. We have to minimize repeating the labs or imaging without any indication. We have to prevent the harm from procedures like we have to do safe transfusions, proper monitoring for iron overload, avoid unnecessary or unsuitable bone marrow transplant or gene therapy recommendations. So this is Thalassemia International Federation, working all over the world, having different member countries under this umbrella. And its mission is to promote and implement national control programs for the prevention and treatment of thalassemia and other hemoglobin disorders in every affected country. This Thalassemia Federation is also working in Pakistan as well, and it's the umbrella organization of all the societies working for thalassemia in the country. And they claim to provide a platform that unites the association so that the exchange of information and experience takes place. Punjab chapter, not only the chapter, different provinces chapters are there, and they have mentioned that in which countries they are operating. So there are 43 total centers, including the public and private centers working for thalassemia. The green ones are the private sectors, and the red one are the public sector thalassemia centers. Punjab Thalassemia Prevention Program it's operating in total 36 districts. Is the most robust thalassemia prevention program in the country, based on the extended family screening of index cases as well as the voluntary screening. And now it has changed to the Punjab Thalassemia and Other Genetic Disorders Prevention and Research Institute, and they mention their activities regularly. So the World Thalassemia Day is celebrated on 8th May to spread the awareness. So the challenges in the control of thalassemia in low and middle income countries, a few of them are mentioned here, that cultural resistance is there, misconceptions, lack of trained counselors, weak legislation enforcement, poor health seeking behavior of the public, cost constraints, inadequate coordination between public and private sectors. What can be the recommended strategies? They should be mandatory premarital screening, nationwide awareness campaigns, strengthen blood transfusion services, establish national patient registry, subsidized chelation therapy, integration with maternal and child health programs, training genetic counselors, and partnering with NGOs already working. So we move on to the recent updates. This is the article regarding the human genetic variations conferring resistance to malaria. So, the human genetic evolution leads to the resistance of the disease, resistance to the malaria. So, thalassemic childs are protected against malaria. Genetic variations associated with malaria resistance, including hemoglobinopathies, and what is the mechanism? It's actually currently incompletely understood. So advances in the thalassemia management and chelation therapy, we have hydroxyurea, and ferroportin modulators and other drugs as well. Uh, Successful treatment as transfusion-dependent beta thalassemia, gene therapy. Gene therapy is the future of the treatment of thalassemia. Currently working as well, and more methods are under experiment as well, and that led to transfusion independence of the patients. So another study, gene therapy, a revolutionary step in treating thalassemia. It states that gene therapy advancements, particularly using CRISPR technology, it functionally cures beta thalassemia patients. And other one is other than the CRISPR technology, lentiviral vectors for hematopoietic stem cell gene therapy. It restores alpha globin expression in alpha thalassemia red blood cells. So they claim in this study that they achieved up to 100% transduction efficiency and safe integration profiles, and these findings establish the safety and clinical potential of this therapy as a promising autologous stem cell gene therapy for alpha thalassemia major. So this was just a brief overview of thalassemia. Now we go to the practice of MCQs. Sorry. First MCQ is a 25-year-old couple, both from a high privilege area, are planning to marry. They are asymptomatic, which is the most effective public health intervention to prevent thalassemia in their future children. Option A, blood transfusion of both partners. Option B, premarital screening with genetic counseling. Option C, routine vaccination. Option D, dietary iron supplementation. And option E, neonatal screening. Option B is the right answer. Question number two is a newborn is found to have severe anemia and generalized edema. His parents are cousins. Which type of thalassemia is most likely? HbH disease. Option B, beta thalassemia intermedia. Option C, hydrops Option D, beta thalassemia trait. Option E, silent alpha thalassemia.
Beta.
As he is having severe anemia, so it's option C. Question number three is a 25-year-old pregnant woman is discovered to be a beta thalassemia carrier. Her husband is also a carrier. What is the next best step in antenatal prevention? Option A, start iron therapy. Option B, ultrasound screening. Option C, test father's HB and offer prenatal diagnosis. D, immediate transfusions. E, bone marrow biopsy. I think it's option C. Uh, Okay, we will see the answer in the next slides. Question number four. A 30-year-old patient with beta thalassemia major has cardiac complications from iron overload. Which preventive strategy could have reduced the risk? Option A, iron chelation, early chelation therapy. B, vaccination. C, iron supplementation. D, premarital counseling. And option E, dietary changes. Yes, option A. Question number five. A health worker is designing an education program to prevent thalassemia in high prevalence villages, which is the primary prevention focus. Option A, lifelong transfusions. B, premarital screening and awareness campaigns. C, iron chelation therapy. D, bone marrow transplant. E, splenectomy. Yes, B. Question number six. A 6-year-old child with beta thalassemia major has severe anemia. What is the first line treatment to maintain normal growth and prevent complications? Option A, oral iron supplements. B, regular blood transfusions. C, folic acid only. D, bone marrow biopsy. E, splenectomy. B. Yes, option B. Question number seven. A child with beta thalassemia major undergoes hematopoietic stem cell transplantation at age 3. What is the expected outcome? Option A, lifelong transfusions still needed. Option B, potential cure. C, only partial reduction in anemia. Option D, no effect on iron overload. And E, requires splenectomy.
Beta.
Yes, beta. Question number 8. A recent therapy for beta thalassemia involves gene editing to reactivate HbF. What is the expected benefit? Option A, complete elimination of alpha thalassemia. Option B, increased fetal hemoglobin to reduce transfusion needs. Option C, iron chelation becomes unnecessary. D, splenectomy is mandatory. E, no effect on anemia. Option B is the right answer. Question number 9 is a patient with severe HBE or beta thalassemia wants to reduce transfusion frequency. Which recent therapeutic approach may help? Option A, folic acid only. Option B, luspatercept or HbF inducing therapy. Option C, iron supplementation. D, splenectomy. E, neonatal screening. Yes, option B. Question number 10. A 4-year-old child with beta thalassemia major receives regular blood transfusions and iron chelation therapy. Which level of prevention does this represent? Option A, primary, B, secondary, C, tertiary, D, quaternary, or E, primordial. Option C, tertiary. Blood transfusions comes under the heading of tertiary. So this is the answer key. This is the YouTube channel of Institute of Public Health Lahore where this presentation will be uploaded. And thank you so much.